Good afternoon, everyone. I welcome you all the participants, our guest speakers, Dr. Sangeeta Sharma and Dr. Jamshed Nair for this lecture series. I also welcome Dr. Jain Srivatsav sir, advisor QPH division, NHSRC. Today we are conducting the 11th lecture series of standard treatment guidelines on the topics of prescribing in liver and renal impairment and also general principles of management of poisoning. Poisoning is a significant public health concern in India. It refers to the deliberate or accidental ingestion or inhalation of the toxic substances that can cause harm to or death. Poisoning cases in India often involve various agents, including chemicals, pesticides, medicines, and household substances. The study says nearly 3 to 4% mortality rate observed in the poison cases, which is preventable sometimes in early interventions. With this short intro, I request Dr. Jeevan Srivatsa sir to address the participants. Over to you, sir.
Thank you, Anpurna. And a very good afternoon to all the colleagues from the states, from the districts, and other institutions and specialty hospitals. At the outset, I extend a very warm welcome to Professor Jamshed Nair, who had taken time out of his busy schedule at AIMS. We can imagine that how busy he would be to be with us, to connect with us, and talk to us. And of course, our sheet anchor colleague, Professor Sangeeta Sharma, has been efforts behind this initiative. I still, in fact, I was just reflecting upon before walking inside the hall. That was perhaps last year only, in the month of September, when this series got conceptualized, and in the first of the start was from Dr. Baviskar talking on the snake bite. And those memories are still fresh. And initially, we had planned that we will run this series for an year or so. But looking at its popularity, its reach, and more importantly, the impact which this series is making, like during the course of travel and otherwise also, when we travel, we interact with the people, and over there the many people have come out, because let's imagine that we are lucky that we are in Delhi serving, one of the best institutions in the country, but the medical officers who is at the primary health center or even in the community health center, where at most there are 2 3 colleagues having a limited knowledge and exposure, and hardly there is any avenue for them to have the professional interface with other colleagues for the progression, because we all know that the medical field, medical knowledge is changing day by day, and in fact at times it becomes very challenging task for all of us to cope with the changes, because the changes are happening so fast. But at same time, let's keep the requirement of our district hospital in mind and lower down the facilities, where in spite of all the penetration of the internet, Google, and other electronic media, still in the real sense, in the in a way where the professional advancement should take place, is not happening. Though the successive governments have spent a considerable sum of money, resource allocations, and whether under NHM or state's own initiative, have been there. But does it really translate into the better health outcomes? Are we able to deliver the improved quality of care? At times, this leaves a serious doubt. So unless we have the better health outcomes, to my mind, the whole initiative, somewhere it loses its intended purpose. And in this context, the improving upon the clinical care, particularly in diagnosing, in managing, the common problems which on day-to-day basis we encounter, and this lecture series tries to address that. In fact, if I look back from the first day topic till today, 11th one is there. We have taken in a very well thought out. These topics have been chosen and mainly addressing the common issues which we come across. In fact, National Health System Resource Center and DPSRDU, led by Professor Sangeeta Sharma, we have been deliberating that how this lecture series could be strengthened further in the phase 2. And perhaps I want to convey to all the states who have joined over here, all the participants from the district, that we are going to take it to the next level. And today's topics are very relevant. We know that the extent of the hepatic or the kidney problems, in fact, both these things are grossly underdiagnosed in the country. Like in the broad sense, about say 3 to 4% of the mortality, depending upon the place and other things, about 3.2, 3.5% of all the deaths are due to hepatic disorders. And about 10% of people suffer from some form of, depending upon the severity, but some form of the renal dysfunction or the suboptimal functions. So, in fact, initial talk with Professor Sangeeta Sharma will dwell, and that once we are having the increased longevity of the life, more people are getting diagnosed with these problems. Having a rational prescription for these two category of the subset of the patients, subset of the populations becomes a challenge. And Madam, I must appreciate the choice of your topic today, and it's very interesting. The second is that poisoning. We all know that how often and how common this problem, and we have got Professor Nair who will talk on these issues. And with the, I won't take much of the time, but certainly all of us are keenly looking forward to the knowledge and the wisdom which both of you will be sharing with us and our colleagues from the state. Thank you very much for this thing. Our ED is on travel to the Chintan Shibir in the state of Dehradun, where all the in the state of Uttarakhand in Dehradun, at the Dehradun, where all the state's health ministers are there. So he has conveyed his best wishes for this lecture series, and certainly in the next one he intends joining. Once again, thank you very much.
Thank you, sir. Thank you for your words of wisdom. With this, we will start. Shall we start the ma'am next session?
Yes,
Yes.
yes.
I request Dr. Sangeeta Sharma ma'am, Professor IBAS and also a President of DSPRUD to take the session on prescribing in liver and renal impairment. Over to you, ma'am.
Thank you, Dr. Srivastava, for providing all the support and encouraging words for this series. With your I could modify, delve into different areas when it comes to medication safety. In the first part of this series, my endeavor had always been to take up some medication safety issue or the other, so that which we need to know when we are handling these patients at the outpatient department or in IPD. And I was looking at the profile of the people, those who have joined us today. We have people from various sectors and people from different levels of healthcare. I will try and see that each one of you have something or the other, taking home or take home messages from the session today. This topic has become very, very important because of the rise in the mortality due to cirrhosis, and globally it leads to 1 million deaths annually, and in India also the magnitude is very high. This is happening most because of three major reasons: chronic alcohol use disorder, viral hepatitis B and C infections, and non-alcoholic steatohepatitis, NASH. Earlier it wasn't recognized as a major cause, but now it has been recognized as that this this is causing cirrhosis in large number of patients. And the rise is seen because of the lifestyle changes, obesity, hypertension, diabetes, all of these are contributing to this NASH here. And this topic is important because it can affect the prescribing or the medication safety in two ways. If one scenario could be that the patient has liver or renal impairment, and then you need to prescribe for them, because they may be having other comorbid situations. Or another situation could be, where the medications are prescribed, but they have harmful effect on the liver and the kidney. So from these two angles, we have to look at this problem. I'll try to, give you examples for this as much as possible. So accordingly, we need to tailor our therapy because pharmacokinetics of the drugs, which includes absorption, distribution, metabolism, and excretion, all these things can be affected by the concomitant disease or the impairment in the target organ functions here. So we need to look at, what are the alternative medications which can be given safely. And often it is also, complicated because the patient may have both liver and renal impairment, or liver impairment then leading to renal impairment, because the combination or the medicines that we prescribe are toxic to the target organ. So sometimes the drug interactions can also affect. So there are this is happening, this is increasing, the severity is also increasing, because both prescription and over the counter medications can cause hepatotoxicity through variety of mechanisms. I'll not go into those things, but if we are able to adjust the dose, it can help prevent adverse drug reactions, for example, acute kidney injury in patients with cirrhosis. And as I said, often cirrhotic patients may have renal function derangement also, so resulting in hepatorenal syndromes, which leads to accumulation of the drug and its metabolite. So that is how increased chances of injury or adverse drug reactions here. There are several drugs, toxins, herbs that have been known to cause liver injury, and this is the most common reason cited for withdrawal of an approved drug. Troglitazone is one of the latest example. There are many risk factors may predispose patients to drug-induced liver disease. Are a female gender is associated with more of drug-induced liver injury. Age, some people are predisposed. Concurrent disease such as obesity, diabetes, co-infection with HIV, polypharmacy, and so therefore withdrawal of the drug generally results in resolution of liver disease, but it may not happen in all the cases. Some people may have a residual damage. So we know that liver is very, very important as it plays a very important role in metabolism, activation, excretion, and interaction between the drug and body. More than 50% of the cytochrome enzymes which are essential for drug metabolism are found in the liver cells. So if there is a moderate to severe hepatic cell impairment, there is a significant alteration in response to drug, because although it has a large cellular reserve for maintenance of hepatocellular activity, and what is very important here is that often we rely on LFT, liver function test, but this routine liver function test does not reflect the actual liver function, because it has a large cellular reserve for this. So this may not be used as a marker you can use it as a marker, but it does not tell you the severity. So hepatic dysfunction is less overt and may not be apparent until much of the functioning of the liver is lost. There are various liver function enzymes which you normally we use it for monitoring of liver function test. Transaminases, GGT, gamma glutamyl transferase, alkaline phosphatase, albumin, INR, and prothrombin. Each one of them has their own significance, and there are indication, they are elevated. For example, transaminases are increased in acute liver disease. There may be, but there may be a false normal because of the reserve. GGT is usually increased in high alcohol intake, or it is also increased in enzyme inducing drugs such as rifampicin, phenytoin. Alkaline phosphatase indicates a biliary damage, cirrhosis. So it can be because, but it can be raised because of extra hepatic causes such as bone disease, malignancy. Albumin low levels indicate chronic liver dysfunction, so it may affect the half-life of many of the drugs which are highly protein bound. And but it could be albumin could be low because of some extra hepatic causes such as malnutrition, inflammatory bowel disease, or malignancy, nephrotic syndrome. INR and PT, they also indicate acute or chronic liver damage. This is useful in assessing the liver's synthetic function, but again, there are other causes for deranged INR and PT. Clinically, you may classify severity of liver disease as compensated or decompensated. Compensated, when you say here the liver is coping with the damage and maintaining its important functions, but often patient does not have any symptoms. Whereas in decompensated, liver function is damaged to the point that it cannot function adequately. There may be serious symptoms such as portal hypertension, bleeding, jaundice, ascites, varicose hemorrhage, hepatic encephalopathy. These are all seen in decompensated, but whereas majority may be initially in decompensated stage where you don't see any symptoms. So don't expect every time when there is a drug induced hepatotoxicity, patient will present like with bleeding, varices, jaundice or something. It may be there beforehand also. This scoring system is used to assign the severity. This scoring system can be used for assigning scoring of this. Now let's get on to the topic here. The liver function, the effect on the pharmacokinetic is, generally oral route is preferred in patients with liver disease, and avoid modified release or long acting preparations as they can accumulate in the body, because the metabolism is slowed down because of the lower cell hepatocellular function here. So these drugs may accumulate in the body. So avoid modified release or long acting preparations. Avoid IM injections because of the coagulopathy which may be coexisting, which can lead to hematoma at the injection site. Topical preparations and patches may cause increased irritation to the skin in patients with liver disease. Rectal route, you have to assess the potential presence of rectal varices and increased risk of bleeding. If this risk is not there, the medicines can be administered by rectal route. Generally, absorption is reduced in the presence of ascites. For example, furosemide, liposoluble medicines, these are less well absorbed in hepatic dysfunction. There may be a alteration of volume of distribution of the drugs due to edema or ascites associated with the decompensated cirrhosis. distribution, especially you need to be careful here with the water soluble drugs, because they can distribute into the ascites. So that means, what does this mean to you clinically? That the lower concentration is achieved in other body areas. So you may have to give a higher dose here to reach that concentration in other body areas. So similarly, this edema and ascites that you see in chronic liver disease may be exacerbated by fluid retention caused by non-steroidal anti-inflammatory drugs. Acetyl salicylic acid, ibuprofen, dexamethasone, prednisolone, they can all exacerbate the edema and ascites in chronic liver disease. And similarly, if you look at the therapeutic response, there may be a decreased therapeutic effect in cirrhotic patients with beta antagonists and certain diuretics. So for these, you may have to give loading dose of these drugs, and if you want to have a rapid peak effect, again loading dose would be required. So it may affect the volume of distribution, affects the volume, the elimination half-life, and accordingly you have to adjust the dose. The metabolism in the liver is affected by the liver blood flow and the functioning cell mass, which is, I told you, is difficult to assess in practice. But if you look at this, because of the decrease in hepatic blood flow and cellular mass, there are a number of the drug metabolizing enzymes decrease. Active drug may persist in the body, may accumulate, because this is not excreted, converted into inactive metabolites, and so it may also lead to enhanced response and increased ADR. So this is how the pharmacokinetics may be affected. The dynamic, as I said, patient may be at risk of increased toxicity and side effect and exaggerated response. So the drug-induced liver disease, that was about the inpatient where there was pre-existing liver disease. Now moving on to the second situation where the drugs cause liver damage. This could be because of the two mechanism of action. One is intrinsic reaction and another is idiosyncratic reaction. As you know, as I told you in the adverse drug reaction session, idiosyncratics are hypersensitivity reactions. These are not predictable, not reproducible, but they do not depend on the dose, but they tend to appear to take longer to occur, weeks to months. They don't appear immediately after giving the drug. It takes weeks to months here. It could be metabolic idiosyncrasy or hypersensitivity reaction. The signs and symptoms of idiosyncratic reaction could be raised LFT, jaundice, fever, rash, and eosinophilia. Whereas intrinsic reaction are more predictable here. For example, paracetamol overdose, when it happens, this is much more, we know more than 3 grams of acetaminophen paracetamol dose can cause liver toxicity. This is reproducible, dose dependent. That is why we ask for not to give paracetamol more often, not to repeat it before 4 hours in case the patient needs it. And also you need to look into the number of other drugs, FDCs, fixed dose combinations, or over the counter medicines that the patient may be taking, may be having some paracetamol in there in the combination. So sometimes because you are not aware, you are not giving the overdose, but because the patient is receiving something over the counter, or another fixed dose combination has some paracetamol in it, so that's how overdose happens. So but this overdose happens within hours, so that's the difference. And this reaction leads to necrosis and acute renal failure. So this is predictable, dose dependent, happens within hours, whereas idiosyncratic reactions may be delayed, unpredictable. So you have to keep this in mind, the nature of the drug, the injury caused by a drug. For example, I'll give you few examples of idiosyncratic reaction here. Acute liver failure can happen with allopurinol, aspirin, cyclophosphamide, and non-steroidal anti-inflammatory drugs. Cholestasis is seen with warfarin, azathioprine, carbimazole, oral contraceptive pills, flucloxacin. Acute hepatitis with phenytoin, isoniazid. Chronic is seen with isoniazid may cause both acute and chronic. Steatosis, amiodarone, corticosteroids, total parenteral nutrition, vascular disorders may happen because of the oral contraceptive pills and azathioprine. So these are the you may like whenever you are using these drugs, you have to be careful about this. Now also there are medicines which are affected by the liver disease. For example, constipating medicines such as opioid, sedating antihistaminics, antimuscarinic agent, they can precipitate or worsen encephalopathy. So medicines that cause gastrointestinal ulcerations like NSAIDs, aspirin, bisphosphonates, they increase the risk of GI bleeding. Sedating medicines like opioid, benzodiazepines, hypnotics, they also precipitate encephalopathy. Anticoagulants like warfarin, aspirin, clopidogrel, painkillers, they increase the risk of bleeding on account of underlying coagulopathy, low platelet count. So although NSAIDs are rarely associated with hepatotoxicity themselves, but because of the risk of bleeding, that it should be used with caution. Then these drugs like diuretics, they affect the fluid and electrolyte balance. So again, encephalopathy may be precipitated or worsened. Antacids, soluble tablets like paracetamol, some IV preparations with high sodium content, again can precipitate or worsen ascites. Painkillers, aminoglycosides, these are nephrotoxic medicines. They can worsen hepatorenal syndrome in these patients. So these drugs should be given with caution. Now because the patient may be having concomitant comorbidities here. So when it comes to antihypertensives, enalapril, nifadipine, they should be avoided. Or you should, general principle in liver disease or any other kidney disease is either you reduce the dose or increase the interval to avoid accumulation of these drugs in the body. These ACE inhibitors, calcium channel blockers, these should be avoided. The diuretics like chlorothiazide, spironolactone, furosemide, again there is a risk of hypokalemia with these drugs. So use these diuretics carefully, as it may cause hypokalemia and may precipitate coma. So use in lower doses here. And also these drugs may increase the risk of hypomagnesemia in alcoholic cirrhosis. Antibiotics, when it comes to, because these are very often they are prone to more infections, so you may be using antibiotics in these patients. Now drugs like anti-tubercular drugs, INH, rifampicin, antibiotic like nitrofurantoin, it should be used with caution. You have to follow when you start therapy with these anti-tubercular drug, watch these patients for renal toxicity in the first 2 weeks. Usually it happens within first 2 to 3 weeks of starting therapy. Once if the patient has elevated enzymes or has jaundice jaundice or has clinical symptoms, you may have to stop all these drugs if the levels enzymes are more than 5 times. If patient is symptomatic, maybe if, LFT is more than 3 times upper normal limit, you again have to stop it. You have to reintroduce these drugs in a phased manner, gradually starting with ethambutol, because ethambutol is the least hepatotoxic. Then introduce INH after 3 days, 4 days, or then add rifampicin. Pyrazinamide is the most hepatotoxic. It is the idiosyncratic reaction, so that is introduced last, or very often, if the patient is not able to tolerate, you have to leave pyrazinamide from the regimen here. Then other antibiotics that you have to monitor are this amoxicillin clavulanic acid. This is used very commonly, especially in patients over 65 years of age, and therapy should not exceed more than 14 days with these antibiotics. Then macrolides, azithromycin. This is mainly metabolized by the liver, so avoid. Jaundice has been reported with azithromycin, so use with caution. Ceftriaxone, again, you have to use reduced dose, monitor plasma concentration in both hepatic and renal impairment. Ciprofloxacin, again, this should not be used in liver disease. These because they are hepatotoxic. Penicillin, when it comes to penicillin, handling is majorly done by the kidney. So you can give penicillins in liver failure, but you have to look at the package insert and the ADRs for individual drugs for possible cholestatic jaundice here. Tetracyclines, they are concentrated in the liver and excreted via bile and reabsorbed in the intestine and eliminated in the urine. So again, tetracyclines should be used with caution in liver disease. Cotrimoxazole, significant metabolism by liver. Chloramphenicol, again, this is conjugated in the liver, so avoid cotrimoxazole, chloramphenicol, and also in addition, chloramphenicol has bone marrow toxicity, so this probability increases. Glycopeptides, they are mainly handled by kidney. Aminoglycosides, they are handled by kidney, so they are safe in the liver patients with the liver disorders. Then there is a whole list, steroids, then antithyroid. General principle is that you reduce the dose here or use them with caution. Oral contraceptives like levonorgestrel, again, this should be avoided in acute liver disease or pruritus, and it can cause recurrent cholestatic jaundice. So principle in liver disease is that you prescribe to a minimum, prefer drugs that are not metabolized by the liver for elimination, and give the lowest effective dose, gradually increase the dose, avoid prodrugs that need hepatic metabolism for activation, avoid, and of course, avoid hepatotoxicity, and review medications regularly and discontinue medications that have potential to cause hepatic impairment. So these should be avoided. Now, the second problem that we see very commonly nowadays is chronic kidney disease. This is a non-communicable disease, usually caused by diabetes and hypertension. And India has become the diabetic capital, and both diabetes and hypertension coexist. They have a strong correlation with each other. And cardiovascular disease is the major cause of early mortality sustained by this chronic kidney disease. So the severity is usually quantified by the low estimated GFR, This indicates poor excretory kidney function and raised urinary albumin. So you measure the urinary albumin to creatinine ratio and electrolytes. Potassium levels need to be monitored in these patients to see. So majorly when we talk about the drug-induced nephrotoxicity, it can lead to both acute kidney injury, AKI, or chronic kidney disease, CKD. So both are seen. So usually these are seen with inappropriate dosing in patients, because they can lead to toxicity and ineffective therapy, especially in elderly who who are at risk of developing advanced disease. Adverse drug reactions are more. This can affect, again, like in liver disorders, CKD, chronic kidney disease, can affect glomerular blood flow, filtration, tubular secretion, reabsorption, renal bioactivation, and metabolism. So pharmacokinetics can be affected. It can affect the drug absorption in the renal system, affecting the bioavailability, protein binding because of the albumin levels, distribution volume, and non-renal clearance. Metabolism can be altered in this. And we know that in elderly, the physiological function declines significantly after 60 years of age. It may on its own decline at the age of 60. By the age of 80 years, it may decline to 70%. So this drug-related injury, acute kidney injury that occurs, there are three different mechanisms. One is direct damage, direct acute tubular injury, or it could be acute interstitial nephritis, or it could be pseudo acute kidney injury because of the obstruction, because of the crystal formation. There may be a direct tubular injury and localized inflammation. The majority of the cases, there are certain drugs which are known to cause direct injury, like aminoglycosides. We know that they are renotoxic. Besides that, this acute interstitial nephritis is seen in more than 25% of the acute kidney acute kidney injury patients. Again, a staging system is used for defining the severity of the kidney dysfunction based on GFR. So there are 5 stages. So accordingly, you have to adjust the dose of these drugs. Either you have to stop them altogether, or reduce the dose, or increase the interval of the drugs. Now, there are many risk factors for drug-induced acute kidney injury. This could, especially look, whenever there is dehydration, or the patient is having hypotension, there are more chances of having acute kidney injury. And exposure to nephrotoxins, there are, and the high level of exposures to high dose or long duration of therapy. Now with aminoglycoside, amikacin, gentamicin, 1 week of therapy with these aminoglycoside may not be so much damaging to the kidney. But if repeated courses or high doses of gentamicin or amikacin are given, it can lead to acute kidney injury. Or so these are all modifiable. That's why I have put them here as modifiable risks, so that you can adjust your prescription accordingly. And of course, there are situations because of the certain underlying disease, the patient may be having CKD, or the patient is having comorbid conditions, liver disease, diabetes, heart failure, major surgery. These are non-modifiable risks. But again, then you have to be sepsis. If you can control the infection at the earliest, perhaps you can modify. But life-threatening septicemia again can lead to acute kidney injury. Now there are drugs, I've listed out some drugs which are very, very important. As a category, you can remember them. I know it's very difficult to remember what drug causes what effect on the kidney, but as a group, if you remember, NSAIDs, they can affect the blood flow in the kidney. They can contribute to kidney damage or failure, and especially those with have comorbid heart failure, liver disease, existing problems. They are at higher risk for experiencing new or worsening kidney problems. Now, you may say, you're using these NSAIDs very regularly. Short-term use does not affect the kidney function, but those of your patients who are on NSAIDs for longer period of time, they are at more risk of developing acute kidney injury. So you have to be really very careful with these patients. Diuretics, you have to be careful, especially in elderly patients, because elderly will have lower blood volume and it can disrupt the filtration. Now, it coming to ACE inhibitors. These are the drug of choice for treatment of hypertension. Generally are considered renoprotective, decrease proteinuria. So they are preferred antihypertensive patients. But again, mild kidney disease may not affect, so you may still use these ACE inhibitors. But patients with moderate to severe renal impairment, or patients especially who are dehydrated or taking other nephrotoxic agents, then you have to give them carefully. Similarly, iodinated radio contrast media, this can also lead to acute kidney injury, and this usually appears within 24 to 48 hours of receiving the contrast. Again, other risk factor may add to the damage. So don't ask for these radio contrast investigations very often in this patient. Aminoglycosides, I told you. Vancomycin, again, this can happen within 4 to 17 days after beginning treatment. And once you stop this drug, the kidney function usually improves after treatment stoppage. Then antiviral drugs, there's tenofovir, you have to give them very carefully in these patients. Digoxin, drugs with narrow therapeutic range, you have to be careful. Lithium, phenytoin, then tacrolimus, because it can lead to nephrotoxicity, and warfarin can increase the risk of bleeding. So you need to monitor INR very closely in these patients. Now, coming to specifically about the renal handling of antibiotics, because these are very often used. Generally, most are excreted by the kidneys. They have wide toxic therapeutic ratio. Dosing regimen needs generally is not altered, but if the clearance is reduced, then you have to decrease the dose by half, or you may have to increase the dosing interval. Or alternative is that, best is, use drugs which are eliminated by the alternative system. If there is kidney impairment, use drugs which are excreted by the liver. Or if there is a liver impairment, use drugs which are excreted by the kidney, then the less impact will be there on the patient. And especially, if you have to, note down here, you may note the antibiotics which need dose adjustment in if there is a major renal excretion of the drug. More than 50% is excreted by the kidney, you need to adjust the dose. Aminoglycosides, polymyxin B, colistin, vancomycin, amphotericin B, carbapenems, miconazole, quinolones, nitrofurantoin. So for these drugs, you need to adjust the dose. Usually, dose adjustment is not required for penicillin, ceftriaxone, cefuroxime, cefoperazone. Majority of the cephalosporins you don't need to adjust. Carbapenems, yes, tetracycline, macrolides, you can administer azithromycin, erythromycin, except clarithromycin. These can azithro and erythro can be administered without any dose adjustment. Then if for the drugs which have excretion less than 15% in urine, chloramphenicol, dalfopristine, linezolid, fluconazole, acyclovir IV, reduced, you need to have give reduced oral dose in these cases. So what, you may be wondering, why are we so penicillins, but especially you have to be careful in chronic kidney disease, because penicillins can lead to neuromuscular toxicity, myoclonus, seizures, or coma. Imipenem can accumulate, cause seizures if dose is not reduced. So use meropenem in advanced diseases. Tetracyclines, except doxycycline, they have anti-anabolic effects. So they may worsen the uremic state in patients with severe disease. Nitrofurantoin has a toxic metabolite that can accumulate, causes peripheral neuritis. And aminoglycosides, that they are nephrotoxic. You need to adjust the dose or interval. Similarly, when it comes to antihypertensive drugs, because these are again very common comorbid conditions, where you need dose adjustment, is ACE inhibitor, beta blockers, amiloride, spironolactone, amphotericin. Oh, sorry, I think these are by mistake here. Dose adjustment usually is not required for furosemide, toracimide, and triamcinolone, but you need dose adjustment for amiloride and spironolactone. And thiazide anti. So I think I already talked about this. With painkillers, there is a risk of acute renal failure. This is 3 times higher. And so you have to be really very careful and avoid concomitant use of diuretics or RAS inhibitors. Maintain hydration in these patients or use alternate analgesics. Monitor these patients every 2 to 4 weeks for several weeks. Acetaminophen can be given safely in patients with renal impairment, whereas meperidine, dextropropoxifen, morphine, tramadol, codeine, they have active metabolites which accumulate, especially in stage 4 and 5. So there is an increased risk of seizures in this patient. So reduce dose or interval of these drugs, and avoid extended release preparations of tramadol in CKD, because they will accumulate and cause. Similarly, hypoglycemic agent, metformin, this should be avoided if serum creatinine level is above 1.5, or the patient is older than 80 years, has heart failure. And please also look at the FDCs with the metformin, because they, many a times we don't know this may be there as one of the ingredient. So you may have to discontinue metformin if you are doing radio contrast, using contrast agent, and then restart if the patient is having renal. Other drugs, the sulfa group of hypoglycemic agents, no adjustment is needed. Acarbose, there is lack of data, so people say avoid. But metformin, you have to be very careful when you are using in renal. I think ball preparation, avoid these phosphate-based preparations. Statins you can use, but in liver function, you have to, because they are hepatotoxic also. So statins should be reviewed in liver disease. Statins can be used in patients with the renal impairment, but you have to look at the individual drug which needs. Now, a special word about proton pump inhibitors and renal injury. These are the group of drugs which are abundantly prescribed, rarely de-prescribed, frequently purchased over the counter, frequently used without medical indication, and when medically indicated, are often used for much longer than needed. People think that these are safe drugs, but now there are abundant reports saying that there is a risk of having non-kidney adverse health outcomes as well as kidney outcomes. So PPI, can cause kidney damage. It can be acute, it can be chronic, it can be, already if the patient is having kidney disease, it can lead to progression, kidney failure, and increase the risk of all-cause mortality and morbidity due to CKD. So please be very careful when you are prescribing PPIs. Don't think that these are harmless medicines. They can affect the target organ adversely and can lead to increased mortality. So always, whenever you have patient, assess kidney function, especially those who have the risk factors, elderly, obese, hypertension, diabetes people, and look at their medication history carefully, including all prescription drugs, OTC, herbal, dietary supplements, vitamin supplements that they are taking. Review them, adjust their regimen, and monitor their therapy for efficacy, or de-prescribe, these drugs, uh, if they are not necessary. So if you want to reduce the risk, kidney injury, must do the risk assessment. Is this the high risk patient? And early recognition is the key here. The moment that you find that there is a kidney effect on the kidney, then you can stop the drug, use an alternative which is safer, or reduce the dose of a drug, or increase the interval. For example, gentamicin, if there is, and if you need to really give gentamicin to this patient, you may increase the interval. If earlier you were giving 8 hourly, now you can give 12 hourly or once daily, depending on the kidney function here. So look for the targeted response. Timely renal support is provided. Many a times patients are held back. They are not referred to a higher level for appropriate management at an early age, out of either ignorance or maybe patient related factors. But timely renal support in the form of dialysis, renal transplantation, all this is needed. And you have to look at the rehabilitation of these patients and keep doing research so that these harms are avoided. Now, if I have to, in terms of medication safety, rational prescribing, there are 4 major strategies that you can use. One is comprehensive medication review. That will tell you a lot about this. And then individualize the approach, tailor medication according to the patient's requirement, preferences, and the goal. De-prescribing is very, very important. I have been saying this in previous sessions also. We are very good at stepping up therapy, but step down doesn't happen. De-prescribing is something that can help prevent polypharmacy, can help prevent the drug-induced damage to the liver and kidney. Now, if there is a renal impairment, must consider if the patient is taking PPI or antihypertensive drugs, which can be given, metformin. If you withdraw these nephrotoxic drugs, perhaps the patient's damage would be, some mitigation will be there. And in case of hepatic impairment, look at the statins, if the patient is on statins, because they can lead to hepatic damage. And communicate with the patient and, educate them about this aspect, because, we know drugs are double-edged swords, have save life on one hand, but have impact on quality of life, morbidity, mortality, unwanted effects, ADR, AMR, or it can lead to waste of resources. So one needs to rationalize this. And one aspect of rationalizing one time-tested tool is the standard treatment guidelines. I've been saying this every time, but I think the more, I can repeat it, n number of times, because this is the major tool that is available that will help you in guiding therapy with this. So we have had standard treatment guidelines since 2002. This is the 6th edition. NHSRC developed 12 detailed expert guidelines on management of 12 diseases. Now ICMR has produced guidelines for infectious diseases, and they also have guidelines for other 100 diseases, but those are more related to the insurance and the claim and the audit purposes. But the basic purpose is that you get evidence based, up to date recommendations about management of these patients. The beauty of these guidelines is that they can help you with the non-pharmacological treatment, pharmacological treatment, and assessment of response to therapy. We very often are very good at starting the pharmacological treatment, but we don't know how to assess response to therapy. Which parameter should be considered, which is not important or not directly related. Then this pharmacological treatment without non-pharmacological treatment will be ineffective. So in hypertension, if you don't control lifestyle or diet or salt intake, or the patient continues to take alcohol, the treatment will remain ineffective. And of course, the patient's education is very important. The drugs that you select are, you use 4 criteria: efficacy, safety, cost, and suitability. For any drug that you may select for a patient prescription, it has to be efficacious. Then just don't go by your past experience. One very good example, is serratiopeptidase. The moment any trauma happens, very often I have seen serratiopeptidase is prescribed. But if you look at the evidence, there are either not many studies doing it, or the literature is very scanty on this. So it has to be efficacious, safe. The side effects should be acceptable here. Cost, yes, for long term diseases treatment like hypertension, diabetes, epilepsy, asthma, you need to choose drugs which are affordable. You have to look at but in the acute emergency department, cost may not be that relevant, but for chronic disease you must look at it. When you are looking at cost, don't just look at the cost of a unit, look at the cost of therapy, because some drugs may be required as a single dose, the other may be required 3 times a day, one may be required for 1 day, 2 day, or the other may be required for prolonged period. So all of these things, there are so many things when you are selecting a drug for the patient. So all these things are covered in the standard treatment guideline. The recommendations are based on evaluation of the medicines on these criteria, and yet you have to be brief and give detail. So this is the beauty. So patient education is very important. We have to involve them, make informed decisions. Many of us disregard this aspect. They will not, saying that they will not understand. I think we have to involve them, because some of the time they may not be aware. They may continue taking a drug which can lead to toxicity, or they don't know the signs and symptoms, when to be concerned, when not to be alarmed, all these things, when to stop treatment. So when should they be visiting next? With kidney disease, disease patients, even the diet, the water intake, the salt intake, there are so many things that you need to regulate. So always must empower them, listen to them and empower them so that they can become equal partner in the therapy. And of course, we have seen that there are many gaps. Today I was focusing on the liver and kidney function, but we in the previous sessions we have seen that there is a lot of inappropriate clinical variation in the management. There are many threats to patient safety, and as part of the quality improvement, we need to see that the patients get the right treatment. So standard treatment guidelines, they help us bridging the gap between current practices and the best practice. So this is the best thing that you have, that you can use this. I think I'll stop here. Next session is on 19th August, and it is on trauma. I think this is something which everyone is, we see these kind of patients in various different settings, and I'll be talking about the drug interactions in the next session. I think I'll stop here. I can take the questions at the end. We have Dr. Jamshed here. Annapurna? Hello? Yeah.
Yeah.
Welcome, Dr. Jamshed here. He is an additional professor of Department of Emergency Medicine, working at AIIMS, New Delhi. He's particularly looking after the poisoning part. He has seen thousands of patients, so I thought he's the right person to talk about this subject. We've had this series with ECHO last year. So your session was very much appreciated. We had a lot of question and answer session after that. So I thought, it's you would be just the right person. Now let me introduce you. He's a gold
Am I audible,
medalist. I have started introducing.
Okay.
Okay. And his special interests are in emergency medicine, toxicology, infectious disease, respiratory, and cardiac emergencies. Being an emergency medicine, I think all of these are very, very important because patients will come up with several different problems. And he's very much academically oriented person, had written many chapters on common poisonings for standard, postgraduate teaching. And then he's also an associate editor of Washington Manual of Emergency. I think this is a very renowned, book on Washington Manual of Emergency Medicine. And plus, along with this, he's been, representing many scientific committees and has been reviewer for many of the reputed journals. With this, I invite you. Over to you, Dr. Jamshed.
Thank you very much, ma'am. Am I audible?
Yes, yes, sir.
Okay, ma'am. Thank you very much for your nice introduction. Can you see my screen?
Yes, we can see.
Okay. So I will be discussing about poisoning, which is very common in the emergency department. Almost 2 to 3% of all emergency visits is because of poisoning. So you must know how to manage these cases, because morbidity and mortality is very, very high if it is not treated appropriately. So the first thing, that what is a poison? It's very rightly said by Paracelsus, who was a Swiss physician, that all substances are poison. There is none which is not a poison. The right dose actually differentiate a poison from a remedy. For example, if you are taking paracetamol, which is very commonly used over the counter, but instead of taking 500 milligram or 1 gram, you take 10 grams. In that condition, you can develop fulminant hepatic failure and you may die because of that. So the dose which decide that whether it is a drug or it is a poison. So it is rightly said by Paracelsus about poisoning. If you see the WHO data, 1 lakhs, more than 1 lakh patients died because of unintentional poisoning. And out of these, 0.2 million was suicidal ingestion and more than 1 lakh was unintentional poisoning. Unintentional poisoning mainly affected the younger age group. Only 47% of the state that poison control centers are available in their states. So this is the data from 2021 as well as 2023. In 2021, it was only 45% of the WHO member who had poison control center. In 2023, there's just addition of 2 member states. So the most important thing that we have to consider that poisoning is very common. How can we reduce the effect of poisoning? It's a preventable disease. We can generate awareness among the population. We can educate them. We can have a poison control center like we have one at AIIMS. So, and toll-free number should be accessible to all the people so that when there is a need, they can call to the poison control center or the poison information center. Childs are very commonly affected because they are unaware about the poisons or the drugs and the adverse effect of the drugs. So every poison or every drug should be packed in a child resistant packaging, and there is a guideline given by the CDC and the WHO that it should be packed in a resistant packages so that child cannot open it, and it should be kept in a locked cabinet up above so that child cannot reach there. Don't keep food and non-food items together. Very commonly we are seeing that the toilet cleaner is kept beside the drinking water, and inadvertently actually they are taking acids instead of water and they are coming with corrosive ingestion in our department. So if you look at the data given by the National Crime Bureau report, this was given in 2014, where out of 1 lakh population, 3.89 actually died. So the mortality rate was around 4%, and this mortality rate has increased in 2021 in the National Crime Record Bureau reports. 23,472 patients died, which constituted 6% of all poisoning deaths. If you look at the epidemiology in the different parts of the country, this is the report from REVA, where pesticides are the number one reasons for poisoning. And similar is the case when it was reported from PGI Chandigarh in the area in and around Punjab. Pesticide along with a snake bite was the commonest reason of ED visits. But in our emergency department, it was mainly corrosive. So there is some changing paradigm as far as the poisoning epidemiology is concerned in the Delhi NCR region. So most of the cases in our emergency department is because of corrosive, because it is easily accessible, easily available in every household. How will you manage a case of poison? The first and the foremost thing that you have to do is you have to resuscitate the patient. Besides, set aside everything, you have to take care of the airway, breathing, and circulation. Once you are done with that, then you can do something to reduce the exposure. Then you can try to find out what is the type of poison, how will you reduce the absorption, and how will you eliminate those poison. And you have to give supportive care to the various organ because of the adverse effect of the poison. And if antidote is only present available for 2% of all the poison. So if antidotes are available in that condition, you can use it. It's a specific therapy. So about the general management, like any emergency patient should be triage read, even if the patient hemodynamics are stable, simply because the reason that it is a time sensitive condition and you have to intervene at the earliest possible. So triage them read. And external decontamination can be used only before ABC in a certain group of the patient. For example, if there is a chemical disaster, I will give a better example when in the subsequent slides. So if there is external decontamination, then you can do, particularly in chemical exposure, radiological exposure, mainly in the chemical exposure, you can decontaminate before doing airway breathing in circulation. The first and foremost thing you have to ask whether the patient airway is patent. It's a bedside decision, and how will you assess the patency of the airway? Ask his name. If he can able to verbalize his name, he can talk to you. His airways are patent. If there is any stridor, any hoarseness, any drooling, then there are chances that the patient's airways is compromised and you have to intubate the patient. But there are challenges in maintaining the airways, particularly in corrosive ingestion. You can see here that airway, there is severe glottic erythema and edema, and it will be very, very difficult. When you are trying to secure the airways, always be ready for the surgical airway management. Most of the patient can have, most of the patient you can intubate, but in certain group of the patient, you should be ready with all the adjuncts of the airway, like laryngeal mask airway. You can intubate, get ready with surgical crate sets. Some of the patient may have cervical spine injuries. In that condition, give an inline manual stabilization of the cervical spine unless you are very sure that there is no spinal injuries. In toxicology, patients can be very, very agitated. In that condition, you first calm the patient by giving some sedatives or giving ketamine. I will discuss later on. For example, there are multiple methods by which you can secure the airway of the patient. The first and the foremost thing which is available and which we are doing right, left, and center is the rapid sequence intubation. But if your patient is very agitated and he is very difficult to control, in that condition, you will not be able to pre-oxygenate the patient, and there are chances that when you are intubating the patient may go into cardiac arrest. So it is better to give ketamine or sedate the patient and pre-oxygenate and then do intubation. So this is known as delayed sequence intubation. If you are not very sure that I will be able to intubate this patient, there are methods. You can do awake intubation. You don't give neuromuscular paralyzing agent, and you try to use adjuncts like fiber optic bronchoscopy or laryngoscopy to intubate the patient. And always be ready with the surgical airways, mainly the surgical prick or the percutaneous pricks. There are patients who will have some breathing abnormality or breathing difficulties. Example, hypoventilation. Any patient who is having altered sensorium, any patient who is having opioid toxicity, he may be hyperventilating. There are chances because patient is in altered sensorium, chances of aspiration is there. Patient can develop ARDS. For example, paraquat poisoning, they may develop ARDS. Opioid poisoning, they may develop ARDS. And in salicylate toxicity, they can have a very high rapid breathing rates. So to give support to the breathing part, it is you give oxygen initially with the help of face mask or nasal cannula, and then you escalate the oxygen therapy. You can go for NRBM, non-rebreathing mask oxygen, where you can give up to 95 to 100% of oxygen FiO2. You can use HFNC, high flow nasal cannula, where you can give 100% oxygen with a high flow. And if patient needed some positive pressure ventilation, you can use first non-invasive ventilation in the form of CPAP or the BiPAP. And if everything fails to actually control the breathing of the patient, then in that condition, it is better to intubate the patient and put the patient on mechanical ventilation. Initially, you have to manage these patients like you manage ARDS. So lung protective strategy is the best one, where you start with 6 to 8 ml of tidal volume, and then you increase or decrease the tidal volume accordingly. If your patient's saturation is not improving, patient is not finding any breathing comfort, in that condition, you can change the PEEP and FiO2 in tandem as advised by the ARDS network. Now coming to the C, which is circulation, hypotension is very common in poison patient. So first of all, give some fluids, mainly in the form of crystalloids, like normal saline, ringer lactate, or balanced crystalloids. And the amount that you have to give initially is 30 to 40 ml per kg. Then accordingly, by doing false protocol and other ultrasonographic guidance and your clinical assessment, you can further give fluid therapy. But initially, you have to give 20 to 30 ml per kg of the fluids. If despite giving fluid therapy, patient's blood pressure is on the lower side, then you can give vasopressor. You should start vasopressor, and the drug of choice initially is norepinephrine. There are some cases, for example, patient is hypertensive because of organophosphate poisoning. In that condition, you have to give atropine. Or the patient is having severe beta blocker toxicity. Apart from these volume replacement, vasopressor, please give glucagon as well, because it is an antidote for the beta blocker toxicity. There are chances that there are some classes of toxin where patient can manifest with hypertension. So if there is hypertension, for example, sympathomimetic toxicity, patient on cocaine toxicity, LSD, they may develop hypertension. So hypertension should be initially treated with benzodiazepine. So there is slight change here. Initially, you should try with benzodiazepine. Then, despite that, if the blood pressure is on the higher side, then add some antihypertensive medications. Now, D, which is decontamination here. Normally, we use D for disability assessment, but here it is decontamination in poisoning cases. So there are a few important consideration here. Do we need a higher level of PPE when we are managing a patient of poisoning? No, not at all. Mostly your face shield or your goggles and your gown and the gloves and N95 mask is sufficient. So you don't need a higher level of PPE unless until you are dealing with a patient who is having CBRNE exposure. For example, chemicals exposure, sarin gas, something like that. Nerve gas agents are there. There are radiological exposure. There are nuclear exposure. Then only you need higher level of PPE. Otherwise, normal PPE that you are wearing in your emergency department is sufficient to protect you. Then should we do pre-hospital decontamination? Yes, if there is an exposure, CBRNE exposure. Otherwise, you can decontaminate the patient inside the hospital. There is no problem with that. But for CBRNE, you have to decontaminate the patient in the pre-hospitals. Third question is, should we resuscitate first or should we decontaminate? Resuscitation should be your priority first, then decontaminate, unless you are dealing with chemical like nerve agents toxicity, where there are chances of secondary contamination to the healthcare workers. Another contentious issue is there any chance that there is secondary exposure to the healthcare workers? Yes. In sarin gas, you would have heard about the Tokyo sarin gas leak, and most of the patient came without any decontamination, directly reached the emergency department of Tokyo Hospital. And in that case, 20 to 30% of the healthcare worker developed secondary exposure to the nerve agents. But overall, if you see, apart from these chemical agents, there is a study which done in 120,000 patients, and out of 120,000 patients, only 9 patients developed secondary exposure to the poisoning agents, which constitute around 0.070075, which is negligible. So unless until you are managing a CBRNE case, there is no need to high level of PPE and should not be conscious enough that you may get exposed to the these toxic agents. Now, in 1970s, it is a very old concept, that is coma cocktail, that any patient who you are suspecting that it could be a case of poisoning and came to ED in comatose state, you give this coma cocktail, which is dextrose, naloxone, thiamine, and flumazenil. The problem is flumazenil, there is a black box warning with the flumazenil according to CDC, and it should not be given unless until you are 100% sure that this coma is because of benzodiazepine overdosage. So in my opinion, it's a very old concept. It is counterproductive, wasteful of your resources, and it is associated with significant adverse events. If a patient develops seizure is very common in poison patient. If your patient is throwing seizures in the emergency department, the best drug to treat seizure due to poisoning is benzodiazepine, and benzodiazepine. You may try levetiracetam, and in resistant cases, you can have propofol and barbiturate. The problem is that a seizure due to poisoning, we sometimes give phenytoin. Phenytoin can be counterproductive because it is a sodium channel blocking agent. Sometimes it itself causes seizures. If a patient is developing seizure, a patient having seizure and controlled seizure because of the isoniazid toxicity and it is not controlled by benzodiazepine, you should give the antidote, which is pyridoxine. And tricyclic antidepressant poisoning, any sodium channel blocking agent poisoning, the drug of choice is sodium bicarbonate and benzodiazepine. So seizures sometimes may be treated in a different manner if it is due to some poisoning. Poisoning can cause agitation and may cause hyperthermia. So if your patient is very, very agitated in the emergency department and 4 to 5 people are actually holding that patient and still patient is not controllable, it is better to give benzodiazepine. You can give antipsychotic like first generation or second generation haloperidol or olanzapine. So don't try to put an IV line because it can cause needleistic injury, and you may not able to actually put an IV line as well. So in that condition, it should be given intramuscularly. And despite the fact that you have given benzodiazepine and antipsychotic, sometime in agitated delirium patient, mainly it happens in sympathomimetic toxicity, you will not be able to control the patient and patient may die in front of you because of the extreme agitation. So in that condition, ketamine is the drug of choice. 4 to 5 milligram per kg of the body weight of ketamine should be given IM, and it will help you a lot. The second problem may be hyperthermia. So if the temperature is very, very high, like anticholinergic toxicity, patient who is having sympathomimetic toxicity, some withdrawal symptoms, patient neuroleptic malignant syndrome, serotonin syndrome, they can have hyperthermia. So you have to take care of the hyperthermia as well. And how will you control the temperature of the body? Rapid cooling is the way out. You have to sometimes immerse the patient in the cold water. And there are multiple studies which say that cold water immersion is slightly better than evaporation technique as far as the rapid cooling is concerned. You have to cool at the earliest possible, possibly within 20 to 30 minutes. Otherwise, your patient may develop rhabdomyolysis, acute renal failure, multi-organ dysfunction, disseminated intravascular coagulation. And apart from that, benzodiazepine should be given to every patient. For example, if patient is suffering from serotonin syndrome or neuroleptic malignant syndrome, first you should try benzodiazepine. Then if it is not controlling the hypothermia, then you can try bromocriptine, dantrolene, and cyproheptadine. Cyproheptadine is the drug of choice in some cases of serotonin syndrome. Similarly, bromocriptine can be given in neuroleptic malignant syndrome. About documentation, these all cases are medical legal cases. So every patient with poisoning, you should make an MLC paper, remove the clothing, packed in a plastic bag, and body fluids, blood, and the urine sample should be properly labeled and properly sealed in front of your eyes, and then you can hand it over to the law enforcing agencies. How will you do the risk assessment of any poison patient? It is first and foremost is the focused history and the clinical examination. Don't think that history and the clinical examination is not very important these days. history and clinical examination is the most important thing, despite the fact that you have so many gadgets, so many lab investigation available to you. Try to identify toxidromes, do some of the basic investigation, and if available, antidotes should be given because it's the specific treatment. In focus history, try to get information from the patient or the attendant regarding medications. If a strip is available, if the bottles are available, if some medications are available, which you can actually see that what is the constituent of the composition of that medication, and you can plan accordingly your treatment. Previous medical records can be helpful. For example, if patient is taking digoxin or tricyclic antidepressant, beta blocker, there are chances that patient or the lithium, which is very commonly seen in our emergency department, patient may have developed toxicity because of these drugs. Try to find out what is the time of ingestion and what is the time of onset. For example, if anyone has taken large amount of acetaminophen, that is paracetamol, initially you may not get any findings, but after 4-5 hours, patient will develop nausea, vomiting, and features of some gas discomfort, and then day 2, day 3, patient may have hepatic dysfunctions. And if there is any chemical exposure, try to find out that it happened in home or at workplace. How will you do clinical examination? The first thing is check vitals. Check and recheck vital because patient may deteriorate over a period of time. So multiple times you have to check the vitals. Check the skin and mucous membrane. Skin is dry or patient is perspiring. What is the condition of the mucous membrane? What is the sensorium? What is the pupillary size? What is the particular odors? For example, I don't find in my clinical practice that this particular odor is helpful in making the diagnosis. For example, if people say that in cyanide poisoning, bitter almond, garlic in organophosphorus point compound poisoning, but I really don't find it very useful. Evidence of any IV drug abuse, you can check their skin, they needle track signs there or not. And you have to find any organ failure or the stigmata of the organ failure. For example, reduced urine output if the patient has developed renal failure or patient has developed some petechial spots on jaundice suggesting of liver failure. Also remember that you have to see what is the muscle tone of the patient. Is there any clonus? Because in serotonin syndrome, you can find clonus. It may be helpful. Is there any hyperparexia? What is the pupillary size? Whether it is reacting to light or not. We always, from our MBBS days, we are very concerned about that. What is the toxidromes? These are nothing but it's a very old concept given by Greenshire and Moffenson and Greenshire, published in Pediatric Clinics of North America. It's nothing but constellation of sign and symptom that points out towards a group of toxin. For example, multiple toxidromes are there: cholinergic, anticholinergic, opioid, sympathomimetic, sedative, hypnotic, serotonin, and withdrawal syndromes. For example, example say cholinergic. The classical teaching is that there is increased salivation, there is increased lacrimation, there may be bronchoria, there may be pupillary constriction, so on and so forth. Similarly, anticholinergic, blind as bat, hot as hair. So opioid poisoning, patient have low respiratory rate, less than 12, then altered consciousness. To pinpoint people, sympathomimetic anticholinergic differentiation is that here skin is dry in anticholinergic. Sympathomimetic skin is, the patient will be drenched with sweat, and the pupillary constriction may be there, but it will be briskly reacting to light. So these are some the important thing which is helpful in making the diagnosis of a poison patient. But be wary that sometimes trauma, metabolic abnormality, metabolic encephalopathy, infectious diseases, surgical cases like subdural hematoma may manifest or sometimes very closely simulate to these toxidromes. So you have to rule out these things as well. There are limitations of toxidromes because maybe they have partial, sometimes you can have partial clinical features, which is suggestive of a particular toxidrome. And they can have a overlap features like someone's opioids plus sympathomimetics simultaneously. They can have multiple xenobiotics, there can be multiple xenobiotic ingestion. For example, patient took opioids, and apart from that, patient have some cannabis infection as well, or the cocaine infection cocaine ingestion as well. So in that group of patient, toxic drones may not be helpful. And multiple recreational designer drugs are available nowadays, which do not follow a particular toxic syndrome. So toxidrome may not be helpful. How will you investigate a patient who is in the emergency department? So blood glucose is very important. Every patient who is unconscious, you take blood glucose level. Measure the blood sugar level, do an ECG, do blood gas analysis. Urinary pregnancy test should be done because it may affect the mother or the child in a different way. You do a urine toxicology screen, and the gold standard is quantitative assay, which is gas chromatography or the liquid chromatography with mass spectrometry. We will discuss each one. Every patient who is in altered mental status, measure blood sugar because it is a great mimicker. It can be the adverse effect of multiple drugs, insulin, OHAs, quinine, salicylate. So if blood sugar level is in the lower side, the simple thing that you can do is give him sugar. If you cannot manage an IV line, IV access is not possible, you can give glucagon at a dose of 3 to 5 milligram intramuscularly. Sometimes hypoglycemia can be very, very refractory. It will not respond to your blood sugar dextrose infusion. In that condition, you can try octreotide at a dose of 50 microgram every 6 hourly. Needless to say that electrocardiography should be done in every poison patient because it is screening. It can be helpful in the management of TCA poisoning mainly, or the sodium channel blocking agent. It can be helpful in digoxin toxicity, and in every patient, ECG should be done. In tricyclic antidepressant, if you see, mainly you have to concentrate on the AVR. Maybe you get that there is a terminal R wave which is more than 3 mm, or the R to S ratio is more than 0.7 mm. If you forget everything about that TCA poisoning, just remember one thing, that it is associated with wide QRS complexes. If you see that after TCA intoxication, there is widening of the QRS complexes, your patient is actually suffered from a significant toxicity. And if it is more than 100 milliseconds, there are 33% chances that your patient develops seizures. And after 160 milliseconds widening, patient develops some arrhythmias, mainly sustained ventricular tachycardia and the ventricular fibrillation. We all know that a slurring of the ST depression can be seen in digoxin toxicity, but important thing is that digoxin toxicity can manifest, any arrhythmias can be manifested in digoxin toxicity except whether there is a high ventricular response. So because it has an AV nodal blocking agent, so arrhythmia with a high ventricular AV nodal block with a high ventricular rate is not possible. And VPCs, premature VPCs is the commonest arrhythmia seen in digoxin toxicity, and bidirectional VT is very, very specific to digoxin toxicity. Lot of drugs and lot of toxicity can lead to QT prolongation. And this QT prolongation, if QT prolongation is more than 500 milliseconds, more than 550 milliseconds, there are chances that your patient will develop torsade or polymorphic ventricular tachycardia. Important thing to remember is that antipsychotic, antiarrhythmic, macrolides, electrolytes, hypokalemia, hypomagnesemia, every electrolyte imbalance can cause QT prolongation. But anyone who came to you with loose motions and vomiting, and you just prescribe him ondansetron and loperamide, and patient went into cardiac arrest, it's because patient can have a baseline QTC prolongation, and you have given two drugs like just to suppress vomiting and loose motion. These two drugs can lead to QTC prolongation, and patient will develop torsade and polymorphic ventricular tachycardia, which can lead to cardiac arrest. There may be Brugada patterns in some of the toxicity, mainly the sodium channel blocker toxicity, loperamide and lithium. You can see here that there is a ST elevation here, which is convexity upward with T-wave inversion. So this is very characteristic, mainly is seen in V1 and V2, and you will not be able to see in other leads. So ST elevation with convexity upward, it is Brugada pattern, and it can happen in some of the toxicity like sodium channel blocker, loperamide and lithium. And it can lead to polymorphic VTAC or sustained ventricular tachycardia. Then do a blood gas analysis, try to find out what is the anion gap. Metabolic acidosis is very common in most of the toxicity. So if anion gap is very, very high, that is more than 14, in that condition, you can have these type of poisoning. And you can remember with a mnemonic which is called mud piles. For example, metformin, paraldehyde, INH, ethylene glycol, salicylate, these all can cause high anion gap metabolic acidosis. So blood gas analysis is must in every poisoning cases. The question is, if patient is having metabolic acidosis, should we give bicarbonate in every patient? No, not at all. Because it will lead to unnecessary paradoxical intracellular acidosis, which can be very, very detrimental to the patient. And if you give bicarbonate, it will shift the oxyhemoglobin dissociation curve to the left. So oxygen will not detach from the hemoglobin and patient will be deprived of oxygen. And multiple studies are there that unnecessarily giving bicarbonate in this patient will lead to increased morbidity and mortality. So where should we give bicarbonates? One indication is in sodium channel blocker toxicity. For example, TCA poisoning, you should give bicarbonate. If patient is suffering from salicylate poisoning, give bicarbonate. And if your patient is on mechanical ventilation and despite increasing the minute ventilation, patient acidosis is worsening or persisting, then in that condition, you can give 1 to 2 milliequivalent per kg of bicarbonate. Now, there is a concept of osmolar gap. It is the difference between the measured osmolality versus calculated osmolality. There is a formula for calculation, and measured osmolality you will get in the arterial blood gas in most of the time. If this gap is more than 10, then most of the time it is suggestive of toxic alcohol. For example, methanol, ethylene glycol. And apart from that, it can be seen in some of the other cases like mad gas, mannitol, alcohol dyes, glycerol. But mainly it is for toxic alcohol. You know, sulfose poisoning can be easily diagnosed with silver nitrate test. Just aspirate the things and give a few drops of silver nitrate, it will turn it black. Oxalate crystal can be seen in ethylene glycol if you do urine analysis. Chocolate brown, if you take out the blood, if color is chocolate blood, mostly it is because of methemoglobinemia. And to detect carboxyhemoglobinemia or methemoglobinemia, there are arterial blood gas, which is having facility of co-oximetry, where they will give exact value of carboxyhemoglobin levels or the methemoglobin levels. Every time I'm getting calls from various hospitals of Delhi that my patient is suffering from some poisoning and I want to do a urine toxicology screen, which is available at your center. I always say that it's not very useful in managing the patient unless until your patient actually the sign and symptom uh, is suggestive of some toxin, then you can try to confirm it by urine toxicology screen. Otherwise, it has a very limited utility in the emergency department. It has a very poor correlation with the clinical presentation, and it is marked by false positive and false negative. Just try to find. Every patient is getting pantoprazole. If you give pantoprazole, it will be positive for THC, tetrahydrocannabinols. If you sedated the patient with midazolam, it will be positive for benzodiazepine. If you gave some painkiller, opioid painkiller, it will be positive for opioids. So it's mostly it is not useful in acute management of the any poison patient, and sometimes it can be very, very misleading. So what is the gold standard? Gold standard is GCMS or the LCMS, which is called gas chromatography, mass spectrometry. But unfortunately, it is not available in most of the center, and it is marked with high tab. That is, turnaround time is high. So that is why it is not very useful in every acutely poisoned patient. But if you want to confirm your poison, the best thing is that you have to do GCMS. How to send the blood sample? It should be serum sample or heparinized plasma, but don't send it in EDTA or the citrate. So it is very important for everyone that if you want to do a quantitative assessment of the poison, send it as serum or the heparinized plasma. Don't send in EDTA or the citrate. Is radiology important, useful in poisoning? To a limited extent. If you are resuscitating the patient, you want to see the IVC, you want to see the B lines in your chest ultrasound, that there is no fluid overload, you can use milli ultrasonography. Pharmacobezoar can be detected in a radiology. If you have aspirated, if the patient has aspirated, there is iron mercury poisoning, then in that condition, your radiograph can pick it. CT is very important. Only yesterday, we have seen one patient with body packers, and we can see that the CT is actually showing multiple packets of cocaine packed inside the body. So that can be helpful. And sometimes MRI is important because Parkinsonism, leukoencephalopathy, because of the toxin can be there, and it can be picked up by MRI. These are the examples that you can see here the packets in body packers. Multiple heavy metal atoms like mercury, lead can be seen in the radiography, and chest radiography, because of some aspiration or some patient developing ARDS, can be picked by radiography. Apart from that, toxins, some of the withdrawal symptoms can be very, very dangerous. For example, alcohol can present with altered sensorium, delirium, tremens. Patient can have multiple seizures. Similarly, benzodiazepine withdrawal, cocaine, opioid. Patient can be very, very agitated, can throw seizures. So if the patient is very agitated in seizure, in that condition, benzodiazepine should be the treatment of choice. Every patient with either alcohol withdrawal, benzodiazepine, or the opioid withdrawal should be treated with benzodiazepine initially, and then accordingly you can tailor your therapy. How will you decontaminate when the patient is poisoned? Should we do NG lavage? So before doing NG lavage or gastric decontamination, you have to ask few questions. For example, is the injection potentially dangerous? Can emptying remove a significant amount? Do benefit outweighs the risk of emptying? Is there any effective antidote which is available? If you think that, so for example, if it is potentially dangerous, yes, you can do it. Can it remove significant amount? Yes, you can do it. Benefit outweighs the risk? Yes. If no effective dose is available, if the answer is yes, then in that condition you can go. Otherwise, it should not be done if the amount is very trivial or agent is non-toxic, it should not be done. If there is a presentation which is late more than 1 hour, should not be done. Rapidly absorbed agent like alcohol, most likely you will not get any help. Is there any prior vomiting? Multiple vomiting may not be useful. And there are some contraindication. For example, caustics like acids and alkali, petroleum products, hydrocarbon, you should not do because there are increased chances of aspiration and the damage to the gastric mucosa or the esophageal mucosa. So, according to American Association of Clinical Toxicology, gut decontamination should not be, it is negative statement, should not be considered unless your patient has ingested a potentially life-threatening toxic agent within 16 minutes. And you can see that in USA, it is only in 0.08% cases of poisoning they're using gastrointestinal discontinuation by doing NG lavage. But unfortunately, in India, it is a very common practice. Even 50% of cases in India, they are getting some NG lavage, despite the fact that it is not very helpful. So it is only done when there is a significant life-threatening ingestion less than 1 hour, number one, and agent is not bound to activated charcoal or there is no active and effective antidote available. If you are doing gastrointestinal lavage, then it should be done with a large bore. It is 36 to 40 French in adults and 24 to 28 French in pediatric age group. Put the patient in left lateral decubitus position because it may lead to aspiration, and before doing it, you have to protect the airways because chances of aspiration is very high, and there are chances that patient may land into respiratory distress. What are the contraindication? If your patient has some unprotected airways, patient is unconscious, don't do it. First of all, protect the airway, intubate the patient, and then you can do it. If patient has caustic ingestion like acids and alkali, hydrocarbon like petroleum products, don't do it. Otherwise, it will lead to injury to the stomach, esophagus, and it will lead to aspiration pneumonia and ARDS. According to studies, if you see that aspiration risk increases to 9% versus 0% if you do NG lavage. There are fourfold increase in intubation rate. It increases the intubation rate significantly. And if your patient is intubated, needless to say that ICU admissions will go up. Unfortunately, despite doing all those things, there's significant amount of poison which remains in the body. That is 30 to 88% will remain despite your NG lavage. And unfortunately, you also propel the agents distally where absorption chances are much higher. About activated charcoal, we are actually giving every patient within 1 hour, but in the other part of the country it is decreasing. You can see that over a period of 10-15 years from 4 to 9%, and children it has gone down further, it is less than percent. But exact rate in how many cases of poisoning we are giving activated charcoal, we don't have the exact data in Indian settings. The dose is 1 to 2 gram per kg of the body weight, and the ratio is basically 10:1. So you have to give 10 times more activated charcoal if the amount of poison is known. So 10:1 ratio should be between charcoal to toxin. Issue is that if there is massive overdose, is there any benefit of giving additional charcoal? Maybe I don't think that it is needed. I remember fails. Fails are, just remember this mnemonic. Fails is actually pesticide, P for pesticide, H for hydrocarbons, A for acids or alkali, I for iron, L for lithium, and S for solvents. So in those cases, which is fail, in these fails, actually your activated charcoal fails to clear the poison and should not be given. So fails refer to those cases, those elements where your activated charcoal failed to give any benefit. Your activated charcoal can reduce absorption in 50 to 75% cases. And if you give multi-dose charcoal, it reduces the intrahepatic and intral circulation, recirculation, which is also known as gut dialysis. So it is helpful in some of the cases. But it is marred with multiple side effects: abdominal fullness, constipation, diarrhea, nausea, vomiting. But most important thing that it will lead to aspiration and intubation in 1 to 2%. Constipation, we are not very much concerned. Nausea, vomiting, we are not very much concerned. But aspiration and intubation can lead to significant morbidity and mortality. What are the contraindications? Is your patient has ingested caustics like acids or alkalis, or there is intestinal obstruction, mechanical obstruction is there, if there is paralytic ileus, or the airways are unprotected, in that condition, even activated charcoal should not be given. So is there any role of multi-dose activated charcoal? So these are the poison where you can give multi-dose charcoal. According to one study which was published in Lancet 2028 by Michael Adelston, it is not very helpful, unfortunately. Mortality was 6.3% in MDAC group, multi-dose activated charcoal, versus 6.8, which was not statistically significant. We are actually giving cathartics along with charcoal. And if you are giving multi-dose activated charcoal, cathartics should be like sorbitol, should be given only once, because multi-dose cathartics can lead to dehydration and dyselectrolytemia, and patient may die because of dehydration and dyselectrolytemia rather than the poison. So is whole bowel irrigation helpful? It is helpful in those conditions where your activated charcoal fails, like iron, lithium, drug packers, lead, or sustained release preparation, like many drugs are sustained release preparation or delayed release preparation. If there is pharmacobezoars formation, and the dose is 1 to 2 liters till the rectal effluent, where the rectal effluent is completely cleared. Unfortunately, it is not very helpful, and you can see that initially 0.11% was receiving whole bowel irrigation, which has further dropped down to 0.08%. So it is not very helpful, and it has a lot of contraindication, like patient having ileus, intestinal obstruction, vital signs, if it is unstable, if there is a gastrointestinal bleed, it should not be given. When to ask for help? So you can consult a toxicologist if available. You can contact Poison Control Center and National Poison Information Center. I have just shared the AIIMS Poison Information Center's toll-free number. So anyone who is in need of any help can call on these numbers. Important to remember that if you are poisoned, or if you think that your child or your kith and kin has been poisoned by something or the drugs, you try to contact these poison control center at the earliest possible, and don't wait for that patient has not worsened, why to call. So if you have any confusion, don't hesitate to call the poison control center. Any rule of increasing excretions? There are concept of alkalization of urine. If you give bicarbonate 1 to 2 milliequivalent per kg and try to maintain urine pH between 7.5 to 8.5, it will help in some of the poisoning. For example, like weak acid, salicylate, they ionizes, and it reduces the absorption of these poison. Unfortunately, it is not very helpful. And if you are giving if you're doing alkalization, you must be careful about the potassium levels, because it will lead to alkalosis and hypokalemia. Now, one thing is very important, that there are some poison which can be removed extracorporeal. For example, with the help of hemodialysis, charcoal hemoperfusion, and the plasmapheresis. So selection of these hemodialysis or hemoperfusion and plasmapheresis will depend on certain things. For example, what is the molecular weight of the poison? If it is less than 5,000, hemodialysis works perfectly fine. If it is between 5,000 to 25,000, charcoal hemoperfusion, more than 50,000 or 25,000, plasmapheresis will be a better option. Low volume of distribution, less than 1 liter per kg, hemodialysis is fine. If it is less protein bound, water soluble, hemodialysis will work wonderfully well. And most important thing, that every patient, despite the fact that it can be cleared by the dialysis, should not be put on dialysis. So if endogenous clearance is less than 4 ml per kg per minute, then only you put the patient on hemodialysis or extracorporeal removal. Or your patient, because of some toxicity or some renal failure if the patient is suffering from renal failure, because some other reason, for example, diabetes, hypertension, and patient is in renal failure, on top of that, patient has consumed some poison. In that condition, hemodialysis should be done. If nothing is working for you, you can still do something to help the patient. If your patient is in shock, cardiogenic shock, for example, beta blocker toxicity, calcium channel blocker toxicity, refractory cardiogenic shock, you can put patient on veno-arterial ECMO till the time patient get rid of the toxins. Similarly, paraquat poisoning or organophosphorus poisoning, where the patient is in respiratory failure, mechanical ventilation, and not responding to your conventional mechanical ventilation. In that condition, veno-venous ECMO can be helpful. And there are studies which suggest that it can reduce mortality from 87% to 48%. Unfortunately, we don't have a strong evidence. We don't have a randomized controlled trial of ECMO in poison patient. We have case report and case series and some prospective studies, but there's hardly any evidence which is level 1 evidence, which can be said as level 1 evidence. But it should be tried in sulfos poisoning, beta blocker or calcium channel blocker toxicity, or the paraquat poisoning. About the antidotes, it can be used. Very rarely we get an effective antidote in poisoning cases, and that is why worldwide it is only seen in 18.5% cases where antidote is used. 99.5% of the hospital had shortage of the essential antidotes, which is recommended by the American Hospital Association survey or the American Association of Clinical Toxicology. 82% of the hospitals they do not have the required antidotes on time, so it led to unnecessary delay of antidote administration. And American Hospital Association survey, they say that 44 antidotes should be stocked in any hospital, and out of that 44, 23 should be available for immediate administration, while 14 should be available within 1 hour. There may be some overlap as well, because 23 and 44 is more than 23 and 14 is more than 44 days. So these antidotes should be stocked, and the recommendation is that which antidote you should actually store. You have to do hazard vulnerability assessment. Like in AIIMS, we have to see that what is the type of poisoning that we are encountering, and you have to keep your antidote accordingly. There should be a strategies for procurement, sharing, and distribution. There may be a dedicated space kept where you can actually keep your antidote stocks. You continuously check the expiry date, and if it is near, then order for resupply. Important thing is that antidote is not a very lucrative business for the pharmaceutical company because of the least use, and it causes a lot of costs. So government has to do something to reduce the cost and pursue that. The company should be eager to produce these antidotes. So these are the few antidotes commonly used in the emergency department. I'm not reading it. You all know that these are, like for example, tricyclic antidepressant, sodium bicarbonate should be used. Any patient who is consumed organophosphate poisoning, atropine is the drug of choice. Similarly, a snake bite, you have to give antivenom. Last but not the least, just 2-3 more slides. High dose insulin therapy is coming in a big way, and it is very, very helpful in aluminum phosphate, sulfos poisoning, calcium channel blocker toxicity, or the beta blocker toxicity. And the mechanism by which it acts is that it helps in overcoming the metabolic starvation of the heart muscles, and it also increases the intracellular calcium levels. So it causes increased inotropy and chronotropy due to suppression by calcium channel blocker or the beta blockers, or the myocarditis because of the aluminum phosphide poisoning. The dose is 1 international unit per kg with glucose. And needless to say that it is the initial dose. You may need higher doses, like up to 10 international unit per kg. And there are case reports where in these cases, they have used up to 22 units per kg of insulin. But when you are giving insulin at such a higher dose, always monitor the potassium level because it can lead to hypokalemia, and it can cause hypoglycemia. Another important thing that you can use in your emergency department is the interlipid emulsions. These are basically used initially for local anesthetic systemic toxicity, that mainly bupivacaine, but it can also be used for beta blockers, calcium channel toxicity. And how it acts, it's a proposed theory is that it acts as a lipid sink where the octanol to water coefficient is K log more than 2. It increases the free fatty acid levels, which is used by the cardiac muscle as as an energy source, and it increases the intracellular calcium level, which acts as an inotropy. And the dose is 20% lipid you have to use, 1.5 ml per kg, followed by 0.25 ml per kg per minute infusion rates. And the maximum dose that you can use in toxicity is 10 ml per kg. It can lead to fat embolism syndrome, sometimes pancreatitis, but mostly it is not very severe. Apart from these general management and the antidote, you have to support the system. For example, if it is central nervous system involvement, cardiovascular function, respiratory function, renal and liver function. For example, renal deterioration is there, you have to give dialysis. Liver abnormality is there, maybe you can go for Mars, or maybe you can go for liver transplantation as in acetaminophen toxicity. Maintain the fluid and electrolyte and acid-base status of the patient or any poison patient. Control the temperature, because temperature, higher hyperthermia can lead to organ failure. So what is the take-home message in any poison patient's management? That number one thing is that you have to resuscitate the patient. Before giving any treatment, take care of the airway, breathing and circulation, and other supportive treatment. As I said that, for example, renal replacement therapy, Mars, or the hepatic transplantation, or the support electrolyte imbalance, care of electrolyte imbalance, blood sugar care. If it is available, antidote should be given because it is the specific therapy. Do decontamination, gut decontamination in a very, very selected cases. Unfortunately, we are doing gut decontamination in every case, which is not useful. There's hardly any role of forced diuresis or MSS by giving ipecac syrups. Sodium bicarbonate can be useful in those poisoning cases where you can see that there is a significant QRS prolongation. And if there is a QT prolongation and torsade, give magnesium. So last but not the least, it is very common saying that you have to treat the patient, not the poison. You have to maintain the resistation and give supportive care. Most of the patient will do better, very, very good without antidotes as well. Thank you very much. If you have any question.
Thank you, Dr. Jamshed, for giving such a comprehensive view about poisoning, its principle, and it's a vast subject. Let me share with you. It's very difficult to put it in a simplified manner, to address the diverse gathering that we have. We have some, most of the people are doctors, but we have some nurses, background people also. So I hope you all found it useful. If you have any questions, you can write in the chat box. I hope take home messages. The last slide is very, very important. We know that now what are the don'ts, which should not be done, which are not supported by evidence, or which are not useful in practice. While people are writing, Dr. Jamshed, can I ask you one thing? In your experience, besides these take-home messages that you have given, what do you find, which should have been corrected, or the right way of, if had the right way, first aid was the right, the patient could have been saved? In your practice, what kind of people come at AIIMS,
There is a changing pattern of poisoning in AIIMS. Unfortunately, initially we used to see more organic pesticide poisoning, but these days corrosives are the number one reason why the patients are coming to AIIMS emergency. And in corrosive, the first and the foremost thing that we have to see is the airway compromise, because it leads to significant glottic edema. So we have to actually safeguard the airway of the patient first. And as I told you earlier, that usually antidotes are not very effective in most of the cases, and it is your supportive therapy and the airway breathing and circulation which is helpful. Even if you are bitten by a snake, if you give good quality supportive care, despite the fact that the antivenom is not available, you can still save most of the patients. So it is always airway breathing circulation followed by your supportive care, and if available, antidotes should be given.
I think that's a very good take-home message. Many times people, those who are in the periphery or the primary health center or CSC, they feel helpless. How to go about it. But as Dr. Jamshed has already, emphasized many times that the resuscitation and the supportive treatment is something that can save the patient. So don't, be in a hurry to refer the patient, but provide this resuscitation and supportive treatment before you refer. Referral maybe for some specific things, antidote, that the facility that may not be there with you, but rest of it I think can be managed. That's what I learned today, that with good supportive care, patient can be managed even in the periphery. uh, there is one question about wild mushroom poisoning. I think.
Mushroom poisoning is not very common, and sometimes I can say that mushroom poisoning is not properly evaluated. Many a time mushroom poisoning can present as diarrhea, vomiting, and we used to treat it as like acute gastroenteritis, unless until patient has developed some renal failure or like amanita, like a severe fulminant hepatic failure. So overall, my experience with Amanita is very limited, but still I can say one thing, that Amanita mortality is very high, and there's hardly any antidote available for Amanita poison, amatoxin. Hemoperfusion sometime may be helpful, sometime plasmapheresis has been tried, but there is hardly any randomized controlled trial. Even it is seen that it is helpful in some of the case series or the case studies. There's hardly any study available where you can see that these things are helpful. But one thing is very clear, that if a patient is in a very bad state, sometime extracorporeal membrane oxygenation and extracorporeal removal may be helpful in Amanita toxin. And unfortunately, I'm not seeing a lot of cases of Amanita toxin in AIMS emergency.
uh, I hope that answers this question. There is another question about sulfa poisoning. How early a person should reach the healthcare facility in sulfa poisoning? Rough time estimate if ingested small amount.
It all
Gurvi.
depends. Uh, there are after some regulation by the government of India that it should not be available in tablet form, and the packaging and the formulation. We are actually seeing decreasing trend of sulfose poisoning, but still sulfose poisoning is very dangerous, and if significant amount of poisoning is there, it leads to myocarditis, where intractable hypotension is there and patient will not survive. Regarding your question that how helpful if you reach early, I can't find in that any antidote is available. People say that if you give gastric lavage or give coconut oil lavage or something like that, activated charcoal, it will reduce. But in my experience, these things are not helpful. I always suggest to my resident and others people as well that what can save is the amount of ingestion that patient has. Is there any prior vomiting or chances of clearance done? How formulation was very old. But if there is fresh one and there is a significant amount of toxicity is there, patient can save only with the help of veno arterial ECMO. If the ECMO facility is there, you can save the patient.
Uh, there is a question about viper bites. It says in severe viper bite where clotting times are prolonged and serum is not extractable due to non-clot formation, how does one perform emergency serum based biochemical tests?
Ideally, we say that if you want to quantify, we want to quantify the amount of poison, then it is important that you go for gas chromatography or liquid chromatography, spectrometry. Otherwise, if it is very clear that it is cobra bite or the carrot bite or the viper bite, you don't want to actually quantify the amount of poison. So it is not needed. What is important that you continuously measure the PTINR of the patient, the APTT, and then manage accordingly. Problem is that if you give certain, for example, Profab, if you give for uh, anti-venom, sometime the activity of these anti-venom may not last to counteract the effect of venom effect, and you may have to give multiple doses. The best way is to continuously monitor the coagulation profile of the patient. And second, we are doing actually 20-minute clotting time and everything, but coagulation profile and the 20-minute clotting time is a better option rather than trying to send it for quantitative assessment.
I think his question is, because
can-
it is non-clotting,
You
so
can.
serum cannot be separated. And if, for example, some
So
of the
if you can,
biochemical tests are done on serum, so how do
so
you do that? I think that's what I
multiple
understand.
multiple GCMS or the liquid chromatography MS, they can quantify even in whole blood. So it is not necessary that it is only serum or the plasma.
Okay.
But my question is, you are doing an exercise which is not needed.
Okay, okay. So not to be bothered about that if this is anyway. Once the anti-snake venom is given, clotting time and all that also starts improving. You can always condition is better. Then there is a question about paraquat poisoning. Few words about paraquat poisoning.
Uh, the only thing that I think that which can help the patient is completely ban paraquat from the market. There is unfortunately hardly any antidote available, and once the patient develops, if a patient has developed significant amount of toxicity, or patient has some abnormality in the X-rays or the CT scan, it will be, most of the time it is progressive. So supportive therapy may be helpful. For example, I have already mentioned that if your patient is having refractory respiratory failure, so you can put the patient on venous ECMO and just pray that patient may be healed. Otherwise, fibrosis will be severe. Patient may need transplantation of the lung.
Any role of magnesium sulfate in self-poisoning?
Not at all. Not at all. There are
One
hardly any
question.
randomized controlled trial or the prospective cohort study which suggests that magnesium sulfate is very helpful. You cannot trust a few the case series or some of the retrospective studies where they say that magnesium sulfate can be helpful. They say that yes, ma'am.
Please carry on. Sorry.
Yes, it's not very helpful. In my personal experience, it's not very helpful.
Okay. Then there is a question about what are the lists of antidotes to be made available at government hospitals? Must available.
American Association of Medical Toxicology, they have listed 44. So even in USA, I have shared one paper where they found out that out of these 44, which was mandatory to keep in the emergency department, 99.5%, you can imagine, I'm talking about USA, 99.5% of the hospital, almost 100%, they don't have all the antidotes in their hospital. And more than 80% was administration was delayed because it was not available. So unfortunately, most of the antidote which is actually suggested by various groups, it is not available in India. Because as I told that it is a very costly affair. Pharma company thinks that it is not a lucrative business for them, and government is not giving them any incentive so that they can actually make it. They are not providing any substrate to produce these. Even in our hospital, sometime anti-snake venom, we are trying to procure maximum antidotes in our hospital, but it is not available in the market. As, for example, a small thing with hemoglobinemia, you try to give methylene blue. It is sometimes I am finding it very difficult to get methylene blue, which is very cheap and available in the market. But you can imagine, okay, Prussian blue. I'm not talking about Prussian blue where you want to give treatment thallium or some heavy metal toxicity. It's very simple things. It is not even available in the very good hospitals and good institutes.
So anyway, but you also said, antidotes are not that helpful also. So don't feel, if you
Yes.
don't have it, don't feel helpless, because anyway, you said effectiveness is very limited here. So you can manage even without that. Okay. What can be done at home for OP poisoning till the patient arrives at the health facility? Home first aid, I think.
Nothing much you can do. Maybe I have already explained about fails as well. People say that activated charcoal can be given safely at home. It is not because pesticide fails to bind with activated charcoal in a significant way. So uh, personally, I feel that if there is a significant toxicity or significant ingestion of OP, you should go to the hospital. Don't try to induce vomiting. Don't do harm. This is what I can say. That don't do harm. Go to the hospital. Don't try even gastric lavage or activated charcoal because it is not very helpful. You have a very good antidote, and that is in the form of atropine. Everything will be fine.
Then there is a question about overdosing with sleeping pills, things like alprazolam. What
It's
should be done?
it's like sedative hypnotics, and the main concern is sometimes respiratory depression. If there is significant overdose, there may be respiratory depression. So, if available oxygen and this can be given, but again, you have to go to the hospital. The important thing is that people say that flumazenil should be given in these cases. Flumazenil, if you are 100% sure that it is benzodiazepine, then only you can try flumazenil 0.2 milligrams initially, and then you can escalate the dose. But unless you are very sure that it's only benzodiazepine, then only flumazenil can be given. Otherwise, it is actually counterproductive. Go to the hospital because respiratory depression is the main reason why patient dies, and an aspiration. Two things important. If there is a level of consciousness goes down, there are chances of aspiration. So in that condition, you go to the hospital, and with supportive therapy, patient will be perfectly fine.
I remember I read it in pharmacology. It is very difficult to die because of the benzodiazepine poisoning.
It's
Because
because ma'am, if there is significant overdose, no, sometimes patient may develop significant amount of loss of consciousness, aspiration, and everything can happen. Sometimes patient may develop hypotension as well. But hypotension
lethal नहीं होते हैं. Respiratory depression can lead to all these things. And Alprax is a short acting benzodiazepine, तो इसका effect भी जल्दी pass off हो जाएगा with supportive treatment. Then first aid for children taking phenyl balls.
Important thing is that it causes camphor. Phenyl balls, camphor can cause seizures. So Most of the time, it doesn't cause anything. But if it is significant toxicity is there and patient is throwing seizures, then you have to get to the hospital at the earliest possible. And usually, patient, if you control the seizures, nothing happens to the patient.
I think role of poison center is very much important. Utilization should be more. You've already shared the toll-free numbers. One should not wait for patient to deteriorate, or when you feel helpless, you don't know where to send, what to do. I think right, early in the, when you see this patient, a poison center should be approached and guidance should be sought. I think even for the antidotes, they can also guide you, what antidote, how to get, where to get.
Always
Which
remember one thing, that poisoning always depends on the amount of intake. So anything which is poison, if it is ingested in large amount, then it is very, very detrimental. I'm not talking about botulinum toxin, where even a small amount can be very, very dangerous, nerve gas agent. But most of the time, if it is in small amounts, similarly in sulfose poisoning, if it is significant intake, nothing else, unless you give a very supportive, very good supportive care. Paraquat poisoning, if significant intake is there, nothing can help the patient. Unless, most of the patient actually lands in a very critical high dependency or the critical care units, where patient is put on ECMO and ventilatory support.
in my hospital, doctor sahab, we see a lot of epilepsy patients. तो कई बार वो youngsters, adolescent patients, वो अपनी phenytoin या whatever जो भी उनकी anti epileptic medicine होती है, वो 20-30 गोली इकट्ठी खा लेते हैं.
So if the patient took phenytoin 20 to 30 tablets, so phenytoin is a sodium channel blocking agent. And if there is QRS widening of more than 100 millisecond, then patient, despite taking phenytoin, can have seizure because of phenytoin toxicity. And if it is more than 160 millisecond, there are chances that patient will develop arrhythmias. That is why there is a word of caution that in every patient who is throwing seizure, you should not give phenytoin. Phenytoin is having a sodium channel blocking agent effect, and it itself can cause seizures in case of toxicity.
हमारे यहाँ पर डॉक्टर साहब वो फोर्स डायलिसिस जैसे आप पर आप आई वाज लिसनिंग टू यू कि वो फोर्स डायलिसिस इज नॉट हेल्पफुल, तो वही फोर्स डायलिसिस ही दे देते हैं.
Forced diuresis is actually useful in some condition. For example, maybe salicylate poisoning, sometime chlorpromamide, carbamazepine, but it's not helpful actually. I have not seen that forced diuresis is, and there is a guideline given by American Association of Medical Toxicology, and they say that forced diuresis should not be done. It is now nowhere recommended in toxicology.
So if required, would dialysis would be better?
It all depends, ma'am. So yes, you are right that dialysis can be given because these drugs, phenytoin, carbamazepine, and other valproic acid, they have large molecular weight, and even they are highly protein bound sometimes. So maybe intermittent hemodialysis may not be useful, but hemoperfusion or the plasmapheresis or exchange transfusion can be helpful.
I think there's one more question. Inhalation of pesticide, how do you manage?
Just wanted to add one thing, ma'am. Just wanted to add one thing, that people think that it is not useful if the molecular weight is large. So there is a guideline, EXTIP group is there, that is extracorporeal removal in poisoning patients. They say that dialyzable means that if you can remove significant amount of toxin in the 6 to 8 hours of dialysis. So based on that, they have classified that very dialyzable, like 30% can be removed in one go, 10 to 30% can be removed in one go, and accordingly, if it is less than 3%, they say that there is hardly any need, because endogenous clearance will be much better than the intermittent or any other modes of dialysis. Yes, ma'am. You are.
What level, for example, if it is phenytoin toxicity, I'm doing this levels for last 25 years, more than that. I hardly see, have seen 60 or more. Majority are around 40 only, or maybe less. So at what level, roughly,
Toxicity, most of the toxin, their clinical feature do not correlate with the toxin levels. So if your patient is having some arrhythmias, some
Okay.
seizures, and it is associated with high levels of phenytoin levels, then in that condition, it is better to go for hemodialysis. Or
Because
any
at high levels, it can cause irreversible damage. Okay, I think there was one question about inhalation of pesticides. How do you manage inhalational injuries?
There are some nerve agents, like for example, which is put in organophosphorus compounds. For example, sarin, tabun. They are very, very dangerous. But overall, exposure of organophosphorus, like malathion, parathion, these things, they do not cause significant amount of toxicity on ingestion, unless until it is nerve agents.
I think there's one again. There is a question about mushroom poisoning, that this is very common in Kashmir, especially people living in forest areas. I think you already covered maybe one or two. He was not there for that. You can say a few words about mushroom poisoning.
I have already explained, ma'am, that mushroom poisoning is very underdiagnosed in our emergency. And as I told you that every diarrhea vomiting is gastroenteritis. We don't even ask that, have you taken mushroom? So many of the mushroom, if you're thinking about poisoning, the major concern is two. One is liver toxicity, if the patient has developed some liver injuries, or there are some mushroom which can cause significant renal injuries. So there should be a history, otherwise it will be very difficult to diagnose.
So if it is very common, then you must ask for this,
Yes, yes.
as a differential diagnosis for this patient. I think we've had a lot of questions. People have stayed through all the 3 hours. Many people tell me, you have such long sessions, but, my participants stay over and they have a lot of questions. So I think that they find it useful, then only they are sitting through the sessions. Thank you, Dr. Jamshed, for your elaborate, description of management of poisoning cases, what to do, what not to do. And I think the participants are now very clear what to do. Don't feel helpless. You can manage, with supportive care, resuscitation, save many lives, and poison centers are there to guide you. You have to just call them and they can help you with that. I think with this we can Annapurna, thank you,
Yes, ma'am.
Dr. Jamshed. You can put the post test link in the chat box and the
Sure, ma'am.
feedback link. Huh?
Yeah. Thank you,
Thank you,
ma'am.
ma'am.
Thank you,
Thank
sir.
you so much.
On
Thank
behalf
you.
of
Thank you.
NHSRC, I thank both Dr. Sangeeta Sharma, ma'am, and Dr. Jamshed Nair, sir, for taking these wonderful sessions on sharing your valuable knowledge on the importance of correct prescribing at liver and renal impairment conditions, and also on the comprehensive management of poisoning. And I extend my thanks to all the participants who attended this lecture series and made it successful. Our next lecture series will be held in the month of August, that is on 19th, and recording of this session can be accessed through the Quality and Patient Safety YouTube channel after the 4 days, and link was shared in the chat box for your usefulness. And certificate for participation issued to the participants who attended pre and post test. For that, any queries, you can even mail us to the stg.webinar@nhsrcindia.org. Once again, I thank you, ma'am. I thank you, sir. And I also thank my advisor, sir, for his support. And also, I thank my IT team for made this session successful without any internet issues. Thank you, sir. We'll
Yeah.
meet on the next month on the 19th. Have a good day. Thank you so much.
Annapurna, post test and feedback link फिर से डाल दो.
Yes,
And
ma'am.
please, we are looking forward to your feedback, and we are also looking forward to the topics that you may be interested in, that you want us to cover in the second season. We will
I
try.
request all
Yeah.
the participants to please mail us the interested topics to take in the next upcoming lecture series through the STG webinar at nhsrcindia.org. I am sharing the email in the chat box. Please share your suggestions and topics to take in the next sessions. Thank you.
Yeah.
Thank you, ma'am.
And please complete the post test. Otherwise, many people are then writing to us that you haven't got your certificate. This is one of the requirements. Please fill it. And I think the questions were easy, relevant to your clinical practice, and are also somehow in one way or the other are the take-home messages too. So it is important that you go through these and hopefully these points will then stay longer, and you will be able to remember longer. Okay, thank you. There's no need to write your email ID in the chat box. Just fill up the post test and the feedback link एक बार फिर से डाल दो अन्नपूर्णा.
Sure, ma'am.
I think we have got post-test around 60 responses. Please complete. In the pre-test, there were about 104 responses. So only those who do both pre and post-test will get the certificate. Please complete this formality. Thank you, Annapurna, and your backup team, IT team, for supporting the event. See you on
19th of
19th
August.
of August next month.
Thank you, ma'am. Bye, ma'am. Have a nice weekend.
Thank you.